costs money, that people do something that costs them money. I mean, that's the same thing as saying a tax. And so, really, if we wanted to change our healthcare system to cooperative, the people would need to vote it in. We can't just enact a law that says in Colorado our healthcare is a cooperative now. So, but how many of you would get a ballot measure that says, will you, donate 5%, or would you be willing to raise your taxes 5% and trust us to give you health care? How many would vote yes on that? Oh. He has all his medical marijuana cards. So my thought is that, and I don't know how many of you work for large employers versus small employers, but I know for me, every year in about October or November, I get this booklet that says, these are your options for insurance next year. And every year it seems like it costs more and gives me less. But I look at it and I think about my family and what illnesses we have and what I want to cover and how much I like my doctor. Like, do I like them enough to spend more for their insurance than one that's cheaper but I have to change my doctor? And then I pick what I want. So what I would like to see happen is that this cooperative be turned into that kind of a plan on paper. So I'm offering you this health care plan in which you get medical, you get dental, you get mental health, you get substance abuse, and then you look here at pharmacy co-payments. Your co-payments are $3 or $5. And you look here on, physician visit payments. If you see a primary care physician or provider, it's no co-payment. If you see a specialist, it's X amount. If you see a specialist on your own without a referral, it's Y. If you don't want to be part of the system at all, this is what we reimburse the doctors, and look on their website and see what they charge, and you pay the difference out of pocket. But anyway, that you would get that, and you would say, now in order to do this, you would need to, as the people of Colorado, be willing to levy a 3% payroll tax on the employer and a 3% payroll tax on the employee, and maybe a luxury tax, or whatever it might be. You don't want it all to be employment-based, because when the economy goes down, people often need more health care, or mental health at least, and you want to be sure you still have enough money to fund your system. So you're going to find some alternative ways of funding that besides just employment-based ways. But anyway, so then ideally you would see this in November of 2013, and at the same time you would see what plans were going to start being available in January, either through your employer or through the exchange. And we're working on, someone's helping us develop a website where you would be able to go in there and put in all your details and what your plan is, and they could tell you what the value of your health care plan is. That's something you might have heard being discussed nationally, that Medicaid is the plan that's valued at 95%. On average, Medicaid pays for 95% of all of your health care costs. And most people's HMOs are like an 85% plan. And some, like Blue Cross Blue Shield, is about a 70% plan in terms of what all your health care costs are. So you'd be able to punch something into the system and it would say, for you working at this place, earning this salary, the plan that you entered cost you this and provides this much health care. Voting for the cooperative would cost you this and provide you this much health care. And then a vote for the cooperative would basically mean that the entire state went to the cooperative model in 2014 or 2015, whenever it happened. A vote against it meant we're just going to move forward with health care reform as it's happening now. Because maybe I'm wrong. Maybe they'll price this out and say, you can't cover everybody and save money, even though you got rid of profit and our market buying power and doing all these incentives for doing the right thing. So it could be that I'm wrong. Or, maybe the big insurers all come in here and suddenly offer us a cheap insurance so that nobody will vote for it, which would be a good thing too. But anyway, so it would end up being a vote for the people. Do we make this change or not? So all that this bill does really is create an authority to get that benefit plan designed, to hire somebody to design that benefit plan and tell us what it looks like and how it would be financed, and turn it into that plan that you would vote on whether you choose this one or what you get from your work. Now, some people have said, well, you don't need law to do that, just do that. But as those of you who work in the health professional field know, the prices that things cost is proprietary information, meaning you can't really, if you go up to somebody and say, what does it cost you to do this? They won't tell you, or they can't tell you sometimes. They don't even know because there's so much, well, I charge these people that much and these people that much, and overall costs this much, and sometimes I get this much profit, sometimes I get that much. It's really hard to get this data from people. Now, Representative Cafalis' All Payer Claims database is trying to start getting some of that captured on paper, but this is very sensitive information, and so I think in order to have the authority to get someone to look at and collect this information, you would need it to come through legislation. And in order to get people to really pay attention to it, I think it would need to come through that way. So all the legislation does is say, we're going to try and create this and have it come back to the General Assembly, and the General Assembly will vote on whether to put this on the ballot or not. So if you vote for this legislation, that's all it requires you to do. It doesn't commit you that you're going to definitely go down this path, because like I said, maybe it won't look as rosy as we think it does. And it doesn't do, it obviously can't put you on the path because that requires a vote of the people. There are other little nuances to the system that I don't know, it depends on your level of interest and understanding about how healthcare is delivered. One thing that happens is, remember I mentioned Denmark and going from 150 to 90 and anticipated to go down to 75 hospitals. Well, in a country or in a state like Colorado, you want to be sure that there are hospitals and emergency services scattered around, because if you happen to be hiking in Lyman or skiing in Telluride and you get chest pain, you want to know that you'll be able to be taken somewhere immediately. And so the overall system would be responsible for being sure that we have adequate delivery and access to emergency care around the state. And the other thing is that, let's say you are making hospitals obsolete. You want to make sure you have enough hospitals for when people need them. And so hospitals might not be making their money just from sick people. You might have to actually put money into keeping a hospital open because you need a hospital to exist there, other than having it have to keep alive because of sickness and disease and billing things. So those kinds of things. And the other thing is, someone I think asked me about people with special diseases like cystic fibrosis, or I always think of people who need transplants. Two things. Well, first let's talk about uncommon for people who need transplants. If you work in the medical field, you'll know that where you get certain really specialized treatment makes a big difference. It can make a big difference in whether you're successful or not, and whether you survive it or not. And so what we'd like to do as a state is have centers of excellence, where those things that people don't have to get very often but are really costly and really technical and really difficult can be performed at those centers of excellence. And so those hospitals need to be supported in another way, so that people who need that kind of care can get them done in the best place possible in the state. And then when somebody chooses to be your primary care provider, or they work in a medical neighborhood or group that are going to manage and take care of your care — I hate using that word manage because it scares people, but are really going to manage your health, I should say, instead of manage your care. Those people would be reimbursed money that's based on the things that insurers price you on right now. Because it's true that some of us are thinner than, not you either, no, are thinner than others, I'm kidding. And then some of us have healthier behaviors than others, and some of us are younger than others, and the cost of taking care of that person won't be the same as the cost of taking care of this person. And we don't want people avoiding me because I have bad marks on my, because I'm heavy, because I'm Hispanic, because I'm over 50. I don't want to be avoided. I want them to be paid fairly for taking on my care. And so that would happen as well. So for people who have unusual diseases, providers would be more for taking care of them. So, did I completely confuse everybody? No. Good. That was all I had for my formal presentation. I'm ready to take questions.
I want to say something about the smart card.
Oh, yes, thank you. Yeah. What we'd like to see happen is one of the, you've probably heard people say this over and over, Colorado is well placed to do innovative things. And I should tell you about the ways in which we're well placed. One is that they've already been working on a statewide information technology system for our state, so that, and it was done toward trying to have telemedicine, where, if you need to see an unusual specialist and you're out in Durango, a doctor doesn't have to fly out there just for you. But it's also done with the idea of getting our medical records available all across the state. So ideally, you would have a card that was almost like a credit card that the doctors could put into a computer that would then pull up your medical record. And also that card could be used literally like a credit card if you are on the independent option, to slide and get billed for your care. Or even just to track your care, and that will be how a lot of the outcome data will be collected, a lot of the usage data and stuff like that. You know, one thing you'll hear people say is, oh, you don't want to give people free medical care because they'll be at the doctor all the time. Now, there are a few people who probably would do that, but most healthy people don't like to go to the doctor's office. But the other thing this kind of system does is it allows you to track. And you see that, wow, there's this person here who goes to the doctor every week. And then you make a plan around them instead of making it harder for everybody because of this one person who does that. So that's the other, all that kind of data could be tracked through the electronic system. It would obviously be backed up somewhere centrally because, I don't know about you, but I've managed to lose a credit card now and again, so you don't want it to be in only one place. But that would allow portability of data so that you don't have to have a test repeated that you had before. And when you show up somewhere, the data is available to the physician, nurse practitioner, provider at that point in site.